So we'll be taking a look at complications of diabetes. There are acute and chronic complications of diabetes, so those will be set up in two different lectures. What is important, and I'm combining this part kind of in the middle, as next we will be looking at nursing management for the diabetic patient. We have discussed the types of diabetes, how they get them, medications that they use for them. So now let's take a look. As far as managing the diabetic patient, we need to obtain, as a nurse, a complete past medical history, drug history, and allergy history. And allergies include drugs, any environmental allergies, any food allergies. And as far as any of the drug allergies, we want to know the duration of the allergy and what actually happens. I mean, do they stop breathing? Do they get hives? Or does it just cause a headache? So those are some of the things that we want to look at. As a nurse, we're going to obtain a complete head-to-toe physical exam. And we're going to look at changes in the skin over insulin injection sites. We talked about rotating those sites. We want to look for impaired areas that appear to be healing poorly. We're going to look for ulcerations or evidence of skin or soft tissue actions throughout the body. Again, these patients are at high risk. We are going to check vital signs. We'll check peripheral pulses, make sure those are doing well. We want to check temperature of extremities. And then again, for the inspection of the extremities, we're going to look for edema, changes in color, which is vascular problem, and again, skin is very important. Decreased visual acuity and visual changes such as blurred vision. We need to know that on our patients. And we're going to look for muscle atrophy, weakness, or loss of sensation. So, those are quite important for your patient. So it's important. One of our biggest things for our patients is education. That's where we advocate the most for our patients. So we're going to do some education on our patient. And before this begins, we need to confer with the primary care physician, nurse practitioner, PA, regarding any of the following. We need to know the type of diet that this patient needs to follow. We want to know the medical regimen. Are they on insulin? Are they going to be taking oral antidiabetics? We want to know materials for insulin administration, such as, are they going to be using a needle and syringe? Will they be using an insulin pen? Do they use an insulin pump? And then we want to know this patient's technique for monitoring blood glucose and their self-testing devices, and the suggested brand of use by the physician. Materials for and frequency of urine testing. So we want to give them stuff so they can check if they have ketones, if they have glucose in their urine. And additional information such as skincare, which is very important, signs of diabetic ketoacidosis, HANKS or HINKS, and hypoglycemia. And we'll discuss these a little bit more later. We also, if the physician feels that the patient needs glucometer monitoring, we want to, again, educate on signs and symptoms of hyperglycemia and hypoglycemia, the importance of weight reduction and why it's necessary, if it is necessary for your patient, and problems that require contacting the physician, such as a skin infection, and pain in the extremities, any visual problems, change in color of the skin or temperature of the skin. If the extremities are starting to be cool now, that needs to be checked out. We need to discuss the importance of following an exercise regimen, and that would be, of course, suggested by the physician. How to integrate the dietary exchange list throughout the day, and the importance of drinking adequate water, especially in warmer weather and when these patients are exercising and they're perspiring a lot. Foot care is going to be very important, and we'll go over that in the next lecture, but this is extremely important. Again, I keep kind of going with the skin and foot care. So The need to consult a physician regarding any type of adjustments on insulin or any oral diabetic medications if the patient becomes ill or cannot eat for some reason. So those are factors. We'll also want to refer to a proper specialist, maybe a podiatrist for their feet, an endocrinologist for the diabetes, a dietitian. Maybe they need some more diabetic education. The ophthalmologist, cardiology. Again, I've said before, diabetes affects every system in the body. So in acute complications, we're looking at diabetic ketoacidosis. And this is a type of metabolic acidosis occurs when there is an acute insulin deficiency or instability to use whatever insulin is available by the beta cells. Don't be surprised to find DKA as the event that diagnoses the patient with diabetes. Oftentimes, especially we see this in children, they come in and they're in DKA. They've been feeling lousy, and the child can wake up, and they bring them to the emergency room, and boom, they find out they're in DKA. Never had any idea. And of course, parents are looking back and going, wow, all those symptoms were there, or those 3 Ps that I mentioned earlier, the polyuria, the polyphagia, and the polydipsia. So hyperosmolar hyperglycemic non-ketotic syndrome, also known as HINK or HHNS, is an acute complication of diabetes. It occurs without the ketosis, so we won't have any ketones in the urine. And so that's important to know. Hypoglycemia is a low blood glucose level. You guys should probably figure that out. But I just wanted, anytime you give an insulin or an oral diabetic to a patient, this is always an adverse reaction to giving these medications. So hypoglycemia, you always just kind of caution that, and you look for signs and symptoms of that. But we will go over that. Diabetic ketoacidosis, also known as DKA. So this is a type of metabolic acidosis. Again, acute insulin deficiency or inability to use what insulin is available by those beta cells. Your patient is going to have some weakness, they're going to be thirsty, they're going to have some anorexia, they're going to have some vomiting, they'll be very drowsy, and they'll have this fruity breath. Almost, to me, in my personal opinion, my experience, it reminds me of the Wrigley's fruity gum. So, and then they can also have the Kussmaul's respirations. You're going to see a blood pH of 6.8 to 7.3. Glucose levels can be anywhere from greater than 300 up to 1,000. Urine positive for glucose and ketones. As far as medical management for this patient, there are going to be 4 things. One is we want to reduce blood sugar slowly, and we'll go over that shortly. We want to correct the fluid and electrolyte imbalances. We want to clear glucose and ketones in the urine. And want to treat any current infection that the patient may have. Again, as sometimes maybe patients are sick, they weren't taking enough, they didn't call their physician to tell them that they were sick and how should they adjust their insulin. Or maybe they were too sick and just couldn't get up out of bed and didn't take any of their insulin. So that they developed this DKA. So it is not uncommon to find a patient that goes into DKA that has been sick. Okay, so DKA is typically seen in patients with type 1 diabetes. And although this is beyond the scope of this course, and it will not be in your exam, but it's important to know, a cerebral edema is the most dreaded complication of DKA. It typically happens within 8 to 12 hours of treatment. Treatment for this is usually mannitol, and again, this is where you will not be tested, but it's important to know is mannitol sits for as long as it sits for a little while. It doesn't get used that often or frequently. So when it sits for a while, it can develop crystals. And if you ever pull out mannitol for a patient, do not administer mannitol when it has crystals. This could also be something on your NCLEX. But again, mannitol is not to be administered anytime you see crystals. Anytime you pull out that IV fluid of mannitol, you shake it up, and if you see crystals, you do not administer it. So again, medical management for our patients is to reduce the blood sugar slowly, because we don't, also another problem is to reduce it slowly is we don't want to cause that cerebral edema. We want to correct the fluid and electrolyte imbalances, clear glucose and ketones from the urine, and treat any infections if they have one. Hyperosmolar hyperglycemic non-ketotic syndrome, HINKS. This is hyperglycemia without ketosis. You're going to see blood glucose levels greater than 500, and I have seen them about 1400 in some patients. The pH is going to be within normal limits. It's going to be 7.35 to 7.45. Again, you don't have those ketones that are causing that acidosis. So that's why. Fluid and electrolyte imbalance, you want to correct that. So in your assessment, you're going to find your patient hypotensive because they're going to be voiding quite a bit. You're going to have some mental changes, thirst, again, dehydration, and they'll be tachycardic from the dehydration, and they may possibly be running a fever. HINK is most common in older adults or the undiagnosed patient with type 2 diabetes. It can occur in those who are prescribed medications that increase blood sugar that aren't diabetic and who require dialysis. Or it can happen in those patients that are taking TPN. Because the client is still producing some insulin in HINKS, which can transport glucose in the cells, fat metabolism is minimal or not affected. And that's the reason that you do not see any ketones in the urine. Medical management for HINKS is IV insulin and the correction of the fluid and the electrolytes. In hypoglycemia, there is too much insulin in the bloodstream relative to the amount of blood sugar. Therefore, blood sugar falls below 70. So, blood glucose, again, is going to be less than 70, and as a result of too much insulin in the blood, these are because patients continue to take insulin or anti-diabetic medications without eating, can be the result of not eating enough caloric intake to compensate for the amount of medications that they were given, exercising more than usual, and alcohol consumption can cause hypoglycemic states. Assessment and management of the hypoglycemic patient. Remember, glucose is the primary source of energy. And think of the brain. The brain needs sugar. So that's very important. So here's how you'll see your assessment. You'll see weakness, a headache, nausea, some drowsiness, maybe the patient's nervous, their hunger, they have some tremors, some malaise, some excessive perspiration, some dizziness, anxiety, difficulty speaking, and if left untreated, seizures and unconsciousness can occur. So your patient might be acting a little off. Again, always check for hypoglycemia. Again, primarily the brain needs its glucose to function properly. So you typically see change in mentation. Now I put some asterisks here for tremors, excessive perspiration, anxiety. This is not in your book, but it's something that we notice in the field, and we educate our patients on. So beta blockers can actually hide the signs and symptoms of hypoglycemia, and they can hide the tremors, they can hide the excessive perspiration, a little bit of the anxiety. Sometimes some patients might get a little tachycardic when they're hypoglycemic, and so of course if they're on a beta blocker, that's going to mask all those signs. So it's just something just to be aware of. Medical management is prompt action to return the blood to its normal glucose levels, which is 70 to 110. Evaluate meds, the current meds that the patient's on. We need to evaluate the meal. What causes patient to become hypoglycemic, and then we can fix the problem. So it is important to remember that if hypoglycemia develops, we must use the rule of 15. And I have it here. It's on page 872. So if hypoglycemia develops, we are going to use the rule of 15. We're going to give 15 grams of rapidly absorbed carbohydrate, and that's on box 51-3 on page 872. And then we're going to wait 15 minutes. We'll recheck the blood sugar and administer another 15 grams of glucose if the blood sugar is not above the 70. Again, we want to get that patient above 70 in that normal 70 to 110 range.